So because of this, there is a natriuresis and thereby BP reduction. And because of this inhibition of absorption of glucose, there is glycosuria, so that can cause reduction in the glucose load, as well as we have other this whenever there is natriuresis, you get a tubuloglomerular feedback mechanism which can cause reduction in the afferent arteriolar diameter, so constriction of the afferent arteriole, so reduction in the GFR, thereby reduction in the proteinuria. Canagliflozin and empagliflozin, these three been approved by FDA, as well as empagliflozin, which is not available in India. Rivagliflozin is available in Indian market, but still it is not FDA approved. So these are the CV benefits. So we have large randomized control trials available with each of these SGLT2. Start from empagliflozin, which is with empagliflozin, then Canvas study, which is with canagliflozin, then declare TIMI, which is with dapagliflozin. So what is CV, which is not completed yet, it is with dapagliflozin, but we just check with this first three RCTs. So EMPAREX study is a study where 100% of patients with ASCVD, whereas with Canvas study, 2/3 of patients who had established ASCVD, and coming to declare TIMI, where 1/3 of population has ASCVD. And with if you have some kind of established ASCVD, so the benefits are simultaneously increased. So if patient has established ASCVD, there is reduction in the CV death as well as all-cause mortality as well as HHF. Whereas if patient doesn't have this kind of ASCVD, where we have seen benefits in the heart failure reduction. So this is a summary of slides with heart failure. So they are unanimous. So if you take DAPA-HF or EMPAR reduced study or in Canvas for that matter, so there is a significant reduction in the heart failure risk. So because of this nature of benefit of dapagliflozin, treatment options for heart failure even in non-diabetic. And the indication for dapagliflozin usage in diabetic people with heart failure with reduced insulin, whereas in non-diabetic people who has the reduction in category screening.
మూడు బైక్లు అది వస్తేనే అదే బైక్లో బ్యాటరీ వేరే బ్యాటరీ బ్యాటరీ
కొంచెం యాంటీనా ఇటు పెట్టండి ఇంకా బైక్ లా చూడను
హలో 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 హలో
Facebook login.
అవునా మాకు కొంత
హెడ్ ఫోన్స్ ఏరా ఈడ పెడితే ఉంటాయారా
సుబ్రహ్మణ్యం
So there is one entity called as incipient heart failure, which is seen in diabetic people. That is unrecognized entity of heart failure. So which is a major cause for morbidity and cardiovascular mortality. So the usage of SGLT2 inhibitors has shown to be unanimously shown to be beneficial in patients who have heart failure, and in patients who have not having any heart failure also, who are going to develop this heart failure, will be benefited. So after having this ARBs, AC, then aldosterone antagonists, sacubitril and diuretics, they are the fifth pillar in the management of heart failure patients. So then coming to CKD. So these are the three studies, landmark studies in the CKD with SGLT2 inhibitors. So one is Credence study, which was with canagliflozin, DAPA CKD with dapagliflozin, empagliflozin with empagliflozin. So here the benefits, the Credence study only included diabetic people, but in other two groups, diabetics and non-diabetics, both groups were included. And the final conclusion from all these studies are, so there is a delay in the progression of the CKD part as well as reduction in the proteinuria. So again, we have very few drugs in which reduces proteinuria. The patient who have CKD and proteinuria, these drugs delay the progression as well as reduction in the gross proteinuria. So thereby they are beneficial. So then coming to combination therapy of SGLT2 inhibitors and DPP4. So already we have discussed, if you can tackle the multiple pathophysiological features of diabetes, so the benefit is much more. So if you combine SGLT2 inhibitors and DPP4 inhibitors, you can target these many steps. So if you see, total these 8 pathognomonic features of diabetes, so almost 7 steps being affected by this combination. So then when you are selecting this combination therapy, which DPP4 inhibitors are superior over other DPP4 inhibitors. So there are some studies with saxagliptin, that is sabertimi, which was actually shown to have increased heart failure risk with saxagliptin. So afterwards there were many studies being conducted. These are the different studies with different gliptins. So only TICO study as well as Carmelina study, TICOS with the sitagliptin, Carmelina with linagliptin has shown to be neutral or non-inferior to placebo in terms of heart failure, whereas alogliptin, that is examined study, as well as saxagliptin, that is sabertimi study, actually has shown to be there is higher risk for heart failure. So because of these benefits of linagliptin and sitagliptin, so when you are combining SGLT2 inhibitors along with DPP4, these two drugs are preferred over other DPP4 inhibitors. Then we'll go with GLP-1 receptor agonist therapy. So we know GLP-1 receptor agonist therapy, majorly they are injectable forms of therapies, but now we have a peptide pill, that is oral GLP-1 receptor agonist is available in the market. And if you see the HbA1 reduction with these drugs, they are more effective than the SGLT2 or DPP4. The HbA1 reduction is up to 1 to 1.5% of reduction. And there is significant weight loss happens with these medications because of multiple mechanisms. And finally, there is improvement in the AST readings. So this is the mechanism of action of GLP-1. So at pancreas, there is a glucose-dependent insulin secretion happens and glucagon secretion will be inhibited. In stomach, motility part will be inhibited. In brain, there is satiety will be enhanced. Then cardiovascular production will be there. And in the muscle, there is improved insulin sensitivity. So these are the GLP-1 like analogs available in the market. So there are once daily agents or once weekly agents. Initially we got this exenatide Byetta, which was given as a BD dose. Now mostly it is not available in the market. But once daily GLP-1 receptor agonist, that is liraglutide, exenatide is available, and recently we got semaglutide, which is oral GLP-1 receptor agonist. And you also see once a weekly therapy, which is exenatide long-acting one, as well as semaglutide subcutaneous therapy, albiglutide and dulaglutide. Albiglutide is not available in India. Dulaglutide, that is no receptor. So the CBD benefits with GLP-1 receptor agonist. If you see this chart, maybe it is complicated, but the sustain 6, then if you take pioneer 6, both are shown to be beneficial in terms of reduction in the heart failure. So the 3B base here it is reduced risk is 0.79 in the pioneer study, and sustain 6 it is 0.74, and leader study it is 0.87. So whereas with lexinidide there is 1.02, there is not much benefit observed with lexinidide. So this is a classification. So one is GLP based therapies, Lira, Sima and dulaglutide. Exenatide based therapies are exenatide and lexinidide. So coming to oral semaglutide, which is available right in the market now. So in different pioneer studies, which has shown to be beneficial and it is superior in HbA1 reduction as well as weight loss when compared with empagliflozin, sitagliptin and liraglutide. So it is more beneficial in terms of weight reduction as well as HbA1 reduction. The usage is once daily treatment, oral therapy, which to be taken in the morning empty stomach. And already we have discussed in a pioneer study that is the oral semaglutide therapy has shown to be beneficial in terms of reducing the heart CVD. Coming to overall safety, which can be given in any individual patient has CKD or GLD or elderly or younger patient, everyone, it is very safe to use. And these are summary of CV outcomes. Already we have discussed this. Then this is the recent guideline based therapy. So already we have discussed that these new drugs are beneficial not only in terms of glycemic control, but also they have additional benefits. That's what they are elevated in the order, in the hierarchy. If you see HbA1c less than 7.1 in the monotherapy part, metformin followed by these two drugs. If patient has high risk of CV, high CV risk, or if patient has established ASCVD, these drugs are much more beneficial. Irrespective of HbA1c, you can go for these drugs. Even if patient has HbA1c between 7.5 to 9, so where dual therapy is preferred, again these drugs are high in the order. And when HbA1c is more than 9, along with insulin, if patient has some kind of asthmatic symptoms, where you can go with these drugs along with insulin. If patient doesn't have any asthmatic symptoms, again you can go with these drugs in a triple combination. The same thing again ADA. So once you categorize the type 2 diabetic patients to have whether patient has some kind of AED or heart failure or CKD, you need to characterize the patient and accordingly you need to start treatment. Start with metformin, then if patient has some kind of ASCVD, where you prefer GLP-1 receptor agonist. If patient doesn't have ASCVD, but secondary agent is the SGLT2 inhibitors. If patient has heart failure, where SGLT2 inhibitors are preferred. If patient has some CKD and proteinuria, again SGLT2 inhibitors are preferred. Whereas if patient doesn't have these things, then you select other agent depending on the patient characteristics. Then coming to what are the modern insulins which are available. So, you know, there are many insulins are available. We have regular insulins, we have short-acting insulins, we have intermediate-acting insulins, we have long-acting insulins. What are the new insulins available in the market at this point of time? So we have in the long-acting category, we have insulin glargine U300 and insulin deglutide. And in case of prandial insulins, we have FIAS, that is faster aspart is available. And in combinations, we have IDEC aspart is available, IDEC lira and IDEC ignarlixia are available, but they are less frequent in the usage. So coming to insulin deglutide, why it is long-acting type of insulin? So whenever you are thinking about a long-acting insulin, that means the insulin association property being improved. So there is a association-dissociation property of insulin. If you increase the association property, so where the insulin becomes long-acting, whereas if the insulin is more of dissociative property, it becomes a short-acting insulin. So if you take insulin deglutide, which is a multi-hexamer type of insulin, because of this multi-hexamer formation, there is a gradual release of insulin into the circulation and the protracted action force is up to 36 hours with this insulin. So what are the benefits with insulin deglutide? So you can give this insulin at any time of the day, that is one advantage. And if you have missed a dose in the morning, you can go in the evening also. So in that way, the insulin therapeutic is preferred over conventional long-acting insulins. Then what are the advantages with this newer insulin? So always whenever you are going with insulin, you always thinking about hypoglycemia. So in this particular kind of study, devote study, where it compared with insulin glargine U100, where there is a significant reduction of the hypoglycemia issue. Whether it is severe hypoglycemia or nocturnal hypoglycemia, both got reduced with the usage of Accutane over insulin glargine. And coming to glargine U300, what is glargine U300? So normally the standard which is available in the market, that is glargine U100. It is U300 means more concentrated form of glargine. So within 1 ml you have 300 units of glargine. So if you see the picture, the surface area of U100 it is more. So that's what that is released fast into the circulation, whereas the surface area of U glargine 300 is small. So the value is very slowly it will be released into circulation. So there is a protracted course of action of this glargine happens. So this is the difference. So there is a slight peak with glargine U300. If you take glargine U300, there is a no peak and the flat curve is there. So the duration of action is also up to 30 to 36 hours with this glargine U300. And with less glargine you are giving into the subcutaneous tissue, so the pain part also very less. And second advantage of this glargine U300 over glargine U100 is the plus or 3 minus window period is there. So patients can take within that 6 hours period. So if you take glargine, you need to take insulin within that 1 hour period, plus or minus 1 hour. Whereas with glargine you can take plus or minus 3 hours. So that is one more benefit with this glargine. And again, the benefit with glargine U300 versus glargine U100, there is a significant reduction in the hypoglycemia. Because there is no peak, so there is low risk of hypoglycemia. Then coming to faster aspart, so this is faster aspart. So normally aspart means where niacin and elastin is added to this aspart, so it becomes very fast acting. So the action starts immediately after taking the insulin, and this can be given after at least up to 20 minutes after the food also, so that you can match postprandial glucose spike. So the reduction in the postprandial hyperglycemia as well as hypoglycemia part is very less with this type of insulin compared to normal rapid. So quickly I am closing my talk. So here I am highlighted. So what are the new drugs available in the market? What are the advantages with these new drugs? And what are the new insulins available in the market? What are the advantages with new insulins over conventional insulins? With this I am closing my talk and thank you all for your patience.
We had such a
Frame current
extensive, I'm not
frame
sure
current.
even I understood 5% of what, because it is beyond our head. We are surgeons. We know how to cut and suture. Right? But now we are slowly encroaching into your territory. That's why I'm here to disturb you in this evening. Well, as Dr. Sumita introduced, I work in Dubai at the moment, but I'm basically from Visakhapatnam. And I'm there since last 8 years. I work with Zuleika Hospital and Prime Hospital in Dubai. So today my task is to put before you, I'm sure you already know, Hyderabad is not is a place where pediatric surgery has been done extensively. So I know that it is not new for you, but I want to just once again re-emphasize, as endocrinologists, as physicians, you may be wondering who is the person who is suitable for metabolic surgery. I will clarify what is this term, because sometimes this term is not used. So I hope to clarify these things. So these are salient points of my talk. All physicians treating diabetes should wake up to the escalating prevalence of diabetes globally. We know it theoretically, but this is becoming actually going under our skin. It is really disturbing that to know the kind of figures now it is escalating globally. So we have to do something about this, otherwise we will be having a lot of complications to handle in the coming days. But the benefits of this particular field of surgery called metabolic surgery, some of you know it, and I think most of you know, but if not, you will be sharing something from that. It should not be hidden any longer from the patients. Patients should have this information and should not be covered or hidden from the benefits of this metabolic surgery, which you soon know. And based upon high quality randomized controlled trials, guidelines for this diabetic associations from all over the globe have now stressed the need to consider and to refer metabolic surgery in every diabetes patient. All cases of obesity, and with respect to India, our obesity level starts at 25 BMI, not 30 BMI like in the West. So all cases of obesity, mild, non-severe and severe obesity categories have clear benefits, and this is based upon randomized controlled trials of type 2 diabetes remission after metabolic surgery. And there are preoperative scores that are available that we can utilize to actually see if a particular patient will respond to metabolic surgery. That means the risk-benefit ratio. If you're subjecting that patient to the surgery, are we going to get that response that we want? That may be a very useful field there are many scores. I'll be sharing one of them, which is commonly used in the East. And we have many procedures, and one of my colleagues will be sharing with you regarding different procedures, but bypass procedures are superior in the diabetic remission. I'm not talking about obesity, diabetes remission compared to just sleeve, which is the commonest surgery that is being done. And also now, I must bring before you that endobariatric procedures which are coming up can be quite effective in the future, because many patients don't want any surgery. The endoscopy procedure is much more acceptable among many people. So these are the few salient points of my talk. I don't have to re-emphasize this. There are some dark facts. The IDF Atlas 10th edition comes that this is the fastest global medical emergency in the 21st century, and is almost reaching $1 trillion by the year 2030. So it is not something that we can just gloss over. And even the predictions, if you look at the predictions, I'm sorry you can't see the figures, but see, they predicted that in 2021 we'll be having only 333 million. But now we have actually 537 million. That means prediction was way below here, and we're having almost 60% more than, or somewhere 50-60% more than what was predicted. So it is accelerating more than our prediction. So we have almost 500 million adults who are diabetics today in the world, and similarly India is known as a diabetic capital. So we are proportionally having a larger number. It is a global emergency. So in 2016, a joint statement was given by many international diabetic organizations which collectively met in London. I will come into that later. But the salient points of their joint statement are like this. Type 2 diabetes, the complex metabolic dysfunction leading to increased morbidity, mortality. I don't have to say that to you. Population-based efforts are necessary for prevention of obesity and diabetes. That is agreed by all. However, those who have diabetes should be given all effective options and not just only one part of it, like oral hypoglycemic or insulin, but every other possibility, lifestyle, and even now that is where we are telling that the efficacy of metabolic surgery the patient should not be deprived of the benefits of metabolic surgery. So, GI tract has become now the target, not pancreas. Now, GI tract is the role in its metabolic regulation. It has become the meaningful target for the management of type 2 diabetes mellitus. Our doctor has mentioned about all the different GIP hormones that are given in the treatment of diabetes for HbA1c reduction. So there is substantial body of evidence now accumulating, including the numerous randomized and high quality randomized control trials demonstrating this. What are they demonstrating? Metabolic surgery can achieve excellent control of hyperglycemia and reduce cardiovascular risk factors. An example is like this. This is a patient we operated in Taiwan during my fellowship. So he was 110 kilos. His HbA1c was 6.8. 6.8, triglycerides 158, BMI 40. So after surgery, look at the transformation. I don't think any drug, any medication can give this kind of transformation, sustainable transformation. He's become 71 kilos, HbA1c is 5.2, triglycerides 75. So you are having a tremendous transformation after surgery. Now, metabolic surgery just was not actually, I would say, did not happen overnight. I can say that. The gastrointestinal operations started in 1880s by people like Bill Roth, who did operations on the stomach and intestine for especially things like cancer, peptic ulcer, or similar situations. So it was done with that intention. Later on, they found out patients who had these operations had a weight loss. So then they said, okay, let us use this weight loss part of this GI operations on patients who are morbidly obese. And there came a phase where they started using very, I would say, extreme cases of anastomosis jejunum to ileum or even sometimes colon, and thereby resulting in severe malnutrition and diarrheas and so many stomach complications. Many of them died. So it went into disrepute, and then people are not using it till somebody else again took it up and started refining this process. There were many kinds of GI rearrangements that were discovered. They did it, and they came up with bypasses. Mind you, all these operations were done open procedures. Imagine a fat patient opening an abdomen and doing. There are many complications because of the wound infection and the suture, dehiscence, and all those things. It was messy. Till laparoscopy was discovered. Laparoscopy again escalated the use of GI operations for weight loss, for morbid obesity. However, as they did this in this year, 1990s, they started discovering this, that these operations that were used for bariatric surgery, that means for weight loss operations, were giving a fantastic result in curing the diabetes of the patients who were overweight. So this is the title. Look at the title. Who would have thought it? An operation proves to be the most effective therapy for adult onset diabetes. So he has actually published almost 83% of patients who underwent this kind of operations for obesity had their diabetes resolved. So that's when the focus started going, okay, in that case, let us start doing operations for curing diabetes or resolving diabetes. So it's not just ASMBS, which is the American Society of Metabolic and Bariatric Surgery, started giving a definition of this. Now, treatment of this metabolic derangements, not obesity alone, treatment of metabolic derangements with the alterations of gut anatomy. The emphasis is not on weight loss, but on diabetes. Now, not only surgeons, even endocrinologists from America, the American Association of Clinical Endocrinologists and American College of Endocrinology, they understood that obesity is not the indicator, adiposity is the indicator. So they started focusing on the adiposity. In other words, a person need not be obese to suffer the illness due to adiposity. As much as you see your patient population, you will find most of your patients are not obese but still have diabetes, especially of Indian phenotype. So they have this, points vary, but the BMI, when you look at it, they may be still 25, 27, but they have diabetes. So it is because of unhealthy fat that is around which is central obesity. So this is 2017, they coined this term, adiposity-based chronic diseases, or ABCD. but it is not so much used among the, I do not know if you are using this term, we still go with diabetes and obesity, but actually it comes under this category of adiposity-based chronic disorders. This is Professor Michel Gagnère, who actually propagated sleep gastrectomy first for the treatment of obesity and also published later on its effects in diabetes. I had the privilege to meet him in Korea, a fantastic professor, teacher. But then the problem is, just because sleep gastrectomy is an operation that many can learn fast and patients also like it, there is no malabsorptive component, it became very commonly used, and today it is one of the commonest surgeries, and it's a fantastic surgery, I agree with that. But what happens is, when you think that when you think that sleep gastrectomy is the only thing, then this is a statement that comes to my mind. If you only have a hammer, then everything looks like a nail to you. So diseases are much more complicated. I believe that this is the approach we should have, where we have the toolkit of operations. So we don't look at a screw and start hammering it with a hammer. Screw has to be tightened with a screwdriver. Okay, or if something is not soft, you can't hammer it and make it soft. There is a plane for it. So similarly, in clinical practice also, each patient needs a different approach for management of diabetes. And then, so I want to share with you some of the anatomical structures of what is this metabolic surgery, what are the common ones. Some of them, there are more than 20 different types of surgeries which are devised and are being experimented, but some of the common ones I'll explain to you. So anatomical change, this is the common anatomy. You have esophagus, stomach, the green is jejunum, the peach color is ileum, and the orange color is colon. I think it's easy, schematic diagram. So this is where the sleep gastrectomy, everything is same, but just that the stomach has become thin like a banana, that is sleep gastrectomy. This is RNY gastric bypass or RUNY gastric bypass. Stomach is transected, made a small pouch attached to the jejunum, and jejunum loop, which is called the elementary limb, which is then attached to the other part of jejunum at a particular predetermined distance. So this becomes a Y anastomosis, Y-like anastomosis, so it's called as a RUNY anastomosis. Next comes the mini gastric bypass, which is same bypass. Bypass means bypassing the stomach and the C loop of duodenum and the upper jejunum. So here bypass is given straight into jejunum, but here there are no two anastomoses. Here in RUNY you have one anastomosis there, one anastomosis here, but here you have only one anastomosis, not two here. So that's why it's called as mini, but anyway now it's called as one anastomosis gastric bypass and not just mini gastric bypass. So there are other operations like sleeve gastrectomy and a bypass added to it. That is, duodenojejunal bypass. So there are so many terminologies. This is a sleeve gastrectomy, but the sleeve is attached to the ileum. It's called a SADI, single anastomose duodenal ileum bypass. So there are many of these operations as metabolic surgery specifically. But the three of them, sleeve gastrectomy, RUNY gastric bypass, and mini gastric bypass are the common surgeries that are done. So in my practice, I would say 25 to 30% is this operation, that is mini gastric bypass, and almost about I would say almost 70% is this, about 5% this one, and there are other things like plication and revision operations which we do. Now, quickly regarding the basic difference between, physiological difference between the sleeve gastrectomy and bypass operation. In sleeve gastrectomy, as you know, I don't have to explain, the food has no bypass, it goes through the entire root of the alimentary tract. So the whole absorption is there, the restrictive element is there, and some this part of the stomach is removed, so the hormones, especially ghrelin, is removed from there. In bypass, as you know, the stomach and the upper part of the intestine is bypassed. So you find this is the bypass part. This is the RUNY, this is the mini gastric. Here also there is bypass, but here only one anastomosis bypass. This is two anastomosis bypass. So what is the difference in their physiology? The physiology difference is, this is a graph. This is my research that I did comparing sleeve gastrectomy and sleeve gastrectomy plus bypass. So the aim of the study was, what is the bypass component that will add to the sleeve? So if you look at it, pre-operatively, endocrinologists, all of you know that the glucose tolerance curve, or the postprandial glucose curve will be like this, isn't it? It takes a long time for the glucose levels to come down. that much. But after sleeve gastrectomy, you see the green color, the curve comes down faster without any medications. The sleeve, the immediate, from the third or fourth day, you find this change happening with the sleeve. But when you do bypass, it's even more lower. So you find that much of additional advantages there. Imagine this multiplied by every meal, 3 times a day, 365 days a year. You see how much of less glucose is actually circulating in the body because of this much of a difference between the operations. So I'm not going into the mechanism action a bit too much, but anyway, there are many major things. One is a change in the gut hormones. Of course, both have caloric deficit part, that means you eat little. But more than that, the diabetes control is not just about caloric deficit alone. It is also about change in the gut hormones, change in the nutrient sensing in the jejunum, and changes in the gut microbial flora, which is seen with bypass only. So these are the changes. Some of the things that are, there are so many things that are being that are proposed, postulated, but anyway, some of the mechanisms of action. Now, I think you are familiar with this. Even in an advanced country like USA, only 52% of patients with type 2 diabetes mellitus maintain a HbA1c of less than 7%. Now, we have wonderful, as you heard, such wonderful medications, drugs available today for managing diabetes, but only 50% of them are able to give this kind of 7% or less than 7% results. So many of them are still uncontrolled by your own guidelines. But fortunately, metabolic surgery is coming into picture, where they have compared many randomized controlled trials. Mind you, they are all randomized controlled trials. The last 20 years, from 2000 to 2020, they have shown that when you compare metabolic surgery with medication, whether the patient's BMI is less than 35 or more than 35, this gives better results. They have established that the bariatric procedures are superior to non-surgical interventions. However good they are, that means including the best pharmacotherapy, best lifestyle, and diet, all those things. Even centers like Cleveland Clinic have said that bariatric surgery cannot be matched, or metabolic surgery to be particular, cannot be matched by any amount of pharmacotherapy or diet and lifestyle therapy. So it gives you fantastic results. So this is one of the examples, just to put the Stampede trial, some of you may know it. It was conducted in Cleveland Clinic. They published their results in 2014 and 2017, if I am not mistaken. So this actually is structured. There are 150 patients divided into 3 50s, 50, 50, 50. The first 50 underwent only medical therapy, diet and lifestyle, the best available. And this 50 went through what we call as Roux-en-Y gastric bypass, and this 50 went through sleeve gastrectomy. And when you compare the results, after 3 years, in the medical therapy, they got only 5% of the patients had a HbA1c less than 6%. And after 5 years, it became only 2% who had a HbA1c less than 6%. Let us look at what happens with bypass and sleeve. You look at the difference, 5% and 38%. So patients with bypass had a 13% of patients who were less than 6% and 29% less than 6% bypass. And sleeve also not anywhere very low. It is also giving fantastic results, 24% after 3 years and 23% after 5 years. What this shows is the power of these operations. And if you really are concerned about reducing the HbA1c of your patients, you should be aware of this, and the patient also should be aware of such treatments that are available. Yes, it is surgery, but it saves lives. So, this is about the BMI. Look at the BMI on the graph. So, with medical therapy, BMI only comes this way. You see, not much of from here to here. The changes are very minimal. Look at bariatric surgery, the BMI falls and it plateaus. And of course, there is again a slight rebound, but definitely not that high. So there is a tremendous difference. Look at the HbA1c. That is our target. The target for bariatric surgery is not 7, it is 6. They put it as 6. Most of the studies put it as 6. So in that case, what we find is, with medical therapy, it doesn't come anywhere near the finishing line. But with bariatric surgery, it comes much closer to the finishing line, almost near 6, 6.5. And one thing to be noted is not that if the patient does surgery, you don't give medications. It has to be not an alternative therapy, it has to be a complementary therapy where you are giving surgery as well as follow up with See, if you look at cancer, you don't operate breast cancer patient and say everything is over. Breast cancer, then you follow the radiotherapy, then chemotherapy, and also hormonal therapy. So similarly, obesity and diabetes also should be given surgery and followed with whatever appropriate therapy to maintain our targets. So it should be a complementary or as a combined treatment of a surgeon and then followed up by a physician, endocrinologist or diabetes. CVD, we talked about so much. CVD, there's almost 15% reduction in the cardiovascular diseases and deaths. So this summary of the 15 randomized control trials done in BMI patients with BMI less than 35 and more than 35. So in this is a snapshot of all the randomized control trials. Very nice graph. So it gives you a picture. If this is the odds ratio in 1. All these randomized control trials, and many of them are not surgeons, many of them are actually endocrinologists and physicians. So they are the ones who publish this, and all the randomized control trials favor surgery. The levels of evidence, so we find in another study where there's 11, the meta-analysis of 11 randomized control study where there's surgery versus medical treatment, it shows that metabolic surgery results in greater improvement of glycemic control, level 1 evidence, reduction of medication uses, level 2 evidence, reduction of cardiovascular risk, disease risk, level 1 evidence, reduction of heart attack, strokes, cancer, overall mortality, level 2 evidence, greater weight loss, level 1 evidence, better quality of life, level 1 evidence. So we are talking about high quality, good studies which show how bariatric surgery is superior to medical therapy in treatment of both obesity as well as diabetes. Now, this is a graph, exact tracing of a graph when I was doing fellowship there in Taiwan. So this patient had a surgery here. I look at, and this is the day of surgery. It was a metabolic surgery done on 11th of May, and by 18th of May, there's immediate fall of sugars. Even the insulin levels requirement came down. Do you know the patient has not yet started losing weight? Maybe he must have not the initial beginning of losing. Even before the weight is lost, before the BMI comes down, there is immediate control of sugar, showing that whatever is happening is weight independent effect of metabolic surgery. This is the group of people who met 2015. It's a landmark meeting of consensus of endocrinologists of various in London. And I wanted to look at this very carefully. It is not a meeting of surgeons, it was a meeting of endocrinologists, people who are like you, and who, there were 60% of them were endocrinologists, and another 15% were all non-surgical fields like cardiology, gastroenterology, general medicine, nutrition, internal medicine. And only this 25% green segment were the surgeons who were doing metabolic surgery, and they came up with this. So these were the different societies: American Diabetic Association, IDF, Diabetes UK, Chinese Diabetes Society, Diabetes India also, and all these, they were all represented there. So this is the algorithm they came up with. The algorithm is patients who are non-obese. If you have a diabetic who is non-obese, that means less than 30 in the West, and for Indians it is less than 27.5. In fact, actually, we have still lower 25, but here, according to the Asians, 27.5. If they are having diabetes, only they are giving non-surgical treatment. Non-surgical treatment, all the beautiful treatment that you have already. So you need to do that. According to this consensus. But obese patients, where they are class 1, class 2, class 3, that means they are 30 to 35, 35 to 40, and above 40. All of them, in spite of the in control, poor control or good control, if it is good control in class 1, you still can stay in non-surgical. This is again a crossover, but here if you compare, you find that even these patients improve well with bariatric surgery. However, if a patient with class 1, 30 to 35 BMI, poor control, you have to consider metabolic surgery. Patient with 40 BMI have to be strongly recommended to undergo bariatric surgery. Now, a point I want to make in this slide is, we find a lot of patients come under this category, non-obese and class 1 in our country. So what do we do with them? Do we refer them for surgery, or we continue medical therapy? This is a place where I think my colleague will be sharing with you about endobariatric procedures for weight loss and diabetes management. So we have procedures now today. Even balloons are used, though they are temporary. Now another fantastic procedure called the endoscopic sleeve gastroplasty is being utilized. That is also a very good procedure. Patients will accept it because there is no cutting of stomach and they are able to get up and go after 12 hours or less than 24 hours home. And even these liners are being again experimental. I don't have time to go into the details. Quickly about prediction scores. This is Professor Lee, who I work with in my this thing, and he proposed this score. It's called the ABCD score. Very simple, you can remember. We had ABCD disorders, similarly ABCD score, where age, BMI, C-peptide, and duration of disease. These are the 4 things you need to know. In fact, by history, you know everything excepting C-peptide levels. If you do a C-peptide level and you use this formula, you find out what score they have, and then you come up with this graph. So if a patient's score is more than 8 here, see 8, you have almost 95% success. If the patient score is less than 4 or less than 3, then you have only about 25 to 30% success. In between, it is like that. So that score will help you whether a particular patient can be referred confidently with good results or not. Contraindications, type 1 diabetes, uncontrolled psychiatric illness. So these patients, you can choose them that you continue with medical therapy. So before I go to the conclusions of this talk, let me go to the sorry. There is no sound. This is just a snapshot of one of the favorite metabolic surgeries that I do. I like this operation, so I thought I'd show. So this is a laparoscopic procedure. There are no big cuts, there are small holes. And through that we enter the stomach. You know this part. And we do we fast forward it, lack of time.
And laptops and all.
The laparoscope is inserted through a small incision in the abdominal wall. The camera sends images to a video, which allows your surgeon to see inside your body without having to make large incisions. Laparoscopic surgery is a low-risk, minimally invasive technique with many benefits, including smaller surgical scars, less pain, shorter hospital stay, faster recovery, and reduced risks of infection. The mini gastric bypass has 2 parts. First, we divide the stomach into a smaller portion, or pouch, that is approximately 1/4 of the existing stomach.
I'm sorry about that, I don't want to take away your time. We'll go to the next one. So, the summary of my talk, so whoever knows the right thing to do and fails to do it, for him, it is sin. That's a statement from the Holy Scriptures, Bible. So, conclusions of this talk. All physicians treating type 2 diabetes mellitus respond to the wake-up call of increasing prevalence of diabetes. Information of this advantage of metabolic surgery should not be suppressed from patients who are seeking advice. Metabolic surgery has been proven beyond doubt by all randomized controlled trials that it is better than medical treatment. All patients with obesity can be referred, who are having diabetes can be referred for metabolic surgery. Pre-operative prediction scores are good for counseling individual patients. Bypass procedures are superior over regular sleeve in case of treatment for diabetes. And endobariatric procedures will probably take an important role in the future. Thank you for your patient listening. Thank you.
He also practiced in and did his training in bariatric from Harvard and is currently practicing right now in India London Gastro Care, Kukatpalli. I would like him to come over on the dais and give his next session for today, which is endoscopic-free gastroplasty. Please welcome him with a round of applause.
ఆడియో కూడా కావాలా చెప్పు.
పెడుతున్నాడు వస్తుందా చెక్ చేయాలి.
ఆయన ఆడియో క్లిప్స్ కూడా వీడియో క్లిప్స్ కూడా ఉన్నాయి.
పెట్టు అయితే పెట్టు.
వీడియో క్లిప్స్
ఆడియో వస్తారా నాకు?
నేను ఆఫ్ చేసిన
ఏడా
రికార్డింగ్ లేదు.
రికార్డింగ్ కాదు, రికార్డింగ్ లేపని వస్తుంది. మాట్లాడమని ఒకసారి. ఏమైంది? ప్రాబ్లం వస్తుందా?
రీడర్ ప్రాబ్లం ఉంది.
తీసుకురా అయితే అది.
ఇది సార్
His friend and himself went to Paradise Biryani and had a challenge to finish the whole thing, but unfortunately he lost 400 rupees that he spent on his biryani because it all came out. So, and I had another lady, interestingly, she exchanged the information that can I drink alcohol? My wife does help in counseling with those patients, so they try to ask all weird questions to her rather than to me. And she came back and said, like, why should she want to drink alcohol in a gastric balloon? I don't know. She said, fine. Okay, she just wanted to test the silicone strength to the strength of the alcohol, I guess. But luckily, it's been, I think she's due to get that balloon removed in November. And she managed quite a drastic loss of weight, almost 30 kilos, I think, on the balloon. And then just going back on the application of endoscopic sleeve gastroplasty, which is one of my favorite procedures, which I love to do them because I only can do 3 movements in this. I don't need to think like these clever surgeons. And I just need to only go inside and stitch the anteroposterior wall. So these patients do make a fantastic changes in them. Especially, I do the check endoscopy prior to the procedure to see, and then I also have a psychologist attached to from my center where it's extremely important what they indulge into and whether they can able to lose weight, and sustain to lose weight is most important thing. And also the financial factors do come into matter with these type of patients. And this particular patient has lost almost 10 kilos, I think, in the first month and managed to lose it. Just going to give an example how this procedure is done. And I don't know if anybody had chance to look at those, the device that I just brought, which is designed to use it for any endoscopy equipment. So what I do is I catch hold of the tissue back towards the scope, and then use the needle exchange from anteroposterior wall so that it continues to stitch all the way around. And it's quite okay to use them on the virgin stomach. And I had opportunity to operate on few patients who previously had surgical procedures. And one neurosurgeon from Andhra Pradesh came to me. He had a sleeve gastrectomy. This particular patient had sleeve gastrectomy, and he was throwing off a lot of food outside. And he asked me to see if I can able to correct that. When I had a look inside the check endoscopy for him, the problem is that he had a partial sleeve where the bottom end of the stomach was being cut and they left the top end of the stomach. What made it difficult was it's giving that gravity effect of turning it around, and then I had to use the endoscopic sleeve to stitch the top end of which to avoid another surgery for him to straighten the whole stomach so that he can able to maintain straight tubes, that he can have that one. And I had another lady, and I had a pleasure to do that procedure with, I don't know who's my colleague here. Anyway, so she had a sleeve gastrectomy done 6 to 10 years ago, I guess. And unfortunately, her husband passed away. And due to depression, she started gaining weight. And she asked me if I could able to help her with the endoscopic sleeve gastroplasty. And revision surgeries with the endoscopic applications are very limited publications in the world, which I could. But normally, this was first designed for patients who started gaining weight, which we all hear that when they had bariatric surgery, the people do gain weight after a certain period of time. The world study shows after 6 years, they tend to go up. So we used to use them for gastric bypass to reduce the pouch size and also reduce the anastomosis area to almost, we put a gastric balloon, the endoscopic CRE balloon to up to 12 millimeters and then stitch around it. That's what we used to do that. And then sleeve patients is extremely difficult in a way because the stomach used to have greater curvature and the lesser curvature. Because they taken away the greater curvature, when you start teaching them, then the stomach starts orienting itself into a chocolate-shaped one, which makes and also the size is so difficult to maintain it. I'll just show you one example here that I have done. Does it come there? It's not coming there. It's fine. The black होता है. I'm sorry about this. So basically, this is a patient who had an endoscopic sleeve gastrectomy before, and then surgical sleeve gastrectomy before, and she started gaining weight, and she put on a lot of weight. So if I pause it here, that's the diameter of the small bowel. Unfortunately, this lady has given me less than 6 hours to do the procedure and go back to home. The reason is that she doesn't want her mother-in-law to know, and she wants to pick the children back from the school. And that's the time that she has given, and that's the hardest task I had to do. She dropped the kids at 8 o'clock, and then she wanted to go back by 3 o'clock after the surgery to pick them up, not even without a cannula. So anyhow, so first of all, it's a revision of a previous surgical sleeve gastrectomy, and there are only a handful of the surgeries being done so far, and not any revised procedures been, or even any significant data being available for these ones, and quite challenging. After this, I have done 4 or 5 in this country so far already with giving the revisions of these previous surgical gastrectomies. So if you just see this one, I'm sorry that this wasn't working, and is it? So that's the diameter of the small bowel. No, it's okay, fine. I'll just carry on. So I want to make her stomach size smaller than the diameter of the duodenum. Duodenum is 2 centimeters. And I have to make the lumen of the stomach slightly bigger than this pen, the diameter. And have a look at that one. So I left some space in the antrum for delayed emptying. And then I have to stitch all the way through. And I was a bit worried because every time you stitch it, it rotates like this. And you have to maintain that process. So if you see this one, that's the lumen, exactly. As I said to you, the size of the pen, the size of the stomach. It's quite challenging and quite rewarding, and she lost 3 kilos in 3 days. And she is very, I think she runs a very, very high turnover business, and she finds it very hard to do the follow-up. She could only do 1 follow-up because she runs around 150 crores turnover business of horticulture in Hyderabad. So anyhow, so she said she's doing well. I do the telephone consultations. She was maintaining very good recovery from this procedure. So, and one more thing I just want to tell you is about this. As Dr. James has said, selecting the right patient and for the right procedure is extremely the key. The patient who got hiatus hernia, if do a sleeve gastrectomy, they have a risk of food coming back into the throat through the nose. I had few patients who come up and knock my door through my referral from a surgical colleague saying, can you do something? Because this guy had some surgery for sleeve gastrectomy, and then he couldn't sleep at night for the last 4 years because every time he eats, the food comes through his nose. And this guy is traveling back to Canada for a holiday or to stay with his family for 6 months, and he can't sustain that. So he came down to my clinic, and what I had to do is that I assessed it. What the problem was that he had hiatus hernia. That's the first contraindication to do the sleeve gastrectomy because it comes back. But with endoscopic sleeve gastroplasty, you always leave some space in the top end, so it sustains that one. So anyhow, so I have to dilate his pylorus and then inject the Botox to release the muscles of the distal sphincter so that to make one straight tube. And the next day morning he came in and I said, I don't know, doctor, what you did. Within 24 hours, you changed my life. So anyhow, he went back to Canada now. That's another one. There's another lady who had a sleeve gastrectomy where it forms like a chair-like form, where what happened was the mid-stomach, after they cut the stomach, it formed a little V-shaped form where the food gets stuck over there, and then comes the regurgitation. With that particular lady, I had to break down the tissue to make it straight, and she made a very good recovery too. So there are the one interesting thing about endoscopic sleeve gastroplasty is that this particular device is actually designed to overcome certain complications from the endoscopic procedures. For example, you're doing early cancer removals like ESD, where if it is within the lumen and it's above the muscle layers, when we do the resections, there is a small risk, around 25%, which is a greater risk actually. So to make a perforation, but this particular machine helps to resuture those linings to avoid any of those leaks. And then since I mastered the technique on this, I think I first started in 2010, and by 2012, it's just been approved to be used in other areas. And then in the next 5-6 years, it become application for endoscopic bariatric procedures. So it's great technique to follow, and it's a fantastic one in my belief. So going back into the talk, and I don't want to take much of your time, I just want to give you little details about the, as Dr. James said, when they do the surgery for bypass, people tend to lose the weight within the few days. That's because of the ghrelin aspect. With any of the endoscopic procedures, we're not interfering with the ghrelin, and people tend to lose weight. And there's a lot of science which we don't understand. And people do say that I eat very less quantity of plate and then I still gain weight. So there's a lot more to know about obesity. So ESG, only just we are resuturing this area, but it doesn't have any effect on the ghrelin, which is a hunger aspect of it anyhow. So, and I have few slides about it. I don't want to bore you about it. And I just want to give you the little taste about what the procedure is. And if anybody wants to play around with the machine, I'm more than happy to pass around. And if you have any questions for me, I'm more than happy to take them now. Good question. It's different from Western world to how it's been marketed in India. So it is quite expensive, even in the Western world. I was charging around 12 lakhs in UK. And now in India, I had to fight for 4 lakhs. And the surgeons do it much less than that. And your results are the gold standards, I agree with that. But the applications of the BMI is much more. And if I have to have a procedure, and I would first try the endoscopy sleeve gastroplasty if I got the money. The reason is that the complications from the endoscopic sleeve gastroplasty are very, very limited compared to, from my experience, and James, it all depends on surgical hands. And I have to fly back in 2014 to this country when I have corrected few sleeve gastrectomies where they went wrong and they had a leak. And one guy was fed parenterally for 4 months and was declared peri-death. And somebody called me to come over in 2014, I guess. I have used the Obesco clip to close that, and at that time wasn't available in India to bring them from overseas. And when I'm bringing, they said, like, I had 3 cases, can you bring 3 of them? So I just closed those leaks at that time. I don't know how common it is with it all depends on surgical skills, I guess. So keeping that in mind, even not long ago, it was 2 months ago, I was called in the middle of the night. Somebody did a sleeve gastrectomy, and I've been called to one of the corporate hospitals to say, can you able to help to close the leak? And the patient flew over from Malaysia. And yeah, it took me 45 minutes to close that leak, and it was great pleasure that she flew back. So there are risks with it, even in a skilled hands, about the potential risks of perforation or leaks from surgical one. I always tell my patient, the gold standard is surgery, but if these are the choices depending on your BMI. If I had a patient whose BMI is 52, I would refuse to do the endoscopic sleeve gastroplasty unless the patient says, I will try this first, because their results are much better with the bypass rather than even sleeve. That's my approach. My selection of patients is extremely very, very meticulous whom I'm going to take, because finally it's the results that matters to me rather than just doing a procedure. Did I answer your question? Probably not. 4 lakhs, yes. Yeah, that's what I charge. Any more? Thank you. Thank you very much.
Thank you so much, Dr. Chandrasekhar Puli, sir, for enlightening upon few more details of the procedure. Now heading over to our next speaker, I would like all our delegates to start the dinner before it's the next day. So I would like Dr. Pavan Dalla sir, who is, he likes to introduce himself to you all, and would like him to come over onto the dais. Please welcome Dr. Pavan Dalla sir.
Good evening, everyone. I'll just straight away start with my topic because it's too late. My topic for today is standard bariatric surgical procedures, an overview, and most of the things were covered by Dr. James actually. So I can skip most of the things. So currently I'm working in Yashoda Hospital, Secunderabad. I'm working as senior consultant surgical gastroenterology there. I just joined here. I'm new to this place. I moved to Hyderabad 8 months back. I practiced in Guntur for 6 years, and this is my timeline. I joined my MBBS in 2000 in Kasturba Medical College, Manipal, Mangalore branch. Then I went to and then I went ahead and did my MS in general surgery from Kasturba Medical College, Manipal. After that, I worked for a year in Pinamani Siddhartha, Gannavaram. Then 2012, I moved to Chennai for my DMB in surgical gastroenterology and liver transplantation. Then I came back in 2015, started as a consultant GI surgeon in NRI Medical College. At the same time, I started a hospital by name Sanjeevani Pivals. Then I continued there for 6 years, and I moved to Apollo Hyderabad, Jubilee Hills for liver transplant in 2001 August. But I had my interest in GI oncology, so I had to move back to Yashoda. So my prime focus is in pancreas cancer, and I did considerable numbers in pancreas cancer, around 90 people's procedures in the last 6 years. And with the help of Dr. Sondra Srikanth, who is an endocrinologist in Guntur, we were able to do approximately around 200 to 250 bariatric procedures, and we were like doing a lot of background research work, like what works for Indian patients and particularly our Telugu people. So for 4 years we dedicated ourselves into bariatrics, and out of 250 odd procedures we had one leak which showed a nightmare to us. So I'll come to the topic straight away, and the basic term bariatrics came from Greek. Bar means weight, as we all know, and aether means treatment, and suffix means pertinent. So if you look at this slide, in the 1990s, the percentage of obesity is quite less across the world, and it has considerably increased in the last 10 years, in the last 2 decades. And it has grown to an extent where there is considerable effect on the economy of countries. And because of that, the whole world is shaken, and now even WHO has to declare it as a pandemic. So that's a serious thing. And because I'm interested in GI oncology, I want to stress on this topic that obesity is a recognized cause for at least 13 varieties of cancers. So it's really a serious issue, and other than just diabetes, there are many comorbidities associated with obesity, and of which, out of my experience, I think obstructive sleep apnea is the most dangerous. So these people, they usually develop this high hypercapnia, and they have high levels of PCO2 in their blood, which has an effect on respiratory trigger centers. Moreover, if you take alcohol over that, the entire respiratory drive is suppressed, and these people tend to die in sleep itself. So they don't even know that they're going to die. That's the kind of pathetic situation they usually face when they have an OSA. So OSA is something I really take it very seriously. Other metabolic problems like hypertension and diabetes, yes, they are slow poisons. They can be taken care slowly and by repeated counseling. But OSA is something that we have to act very fast. And you have other issues like CAD, CVA, then urinary incontinence, osteoarthritis, all these issues are there, varicose veins, then joint problems, high cholesterol levels, all those things. So based on my experience, I can simply put it in three different scenarios, like where people usually consume excess calories. That's the first point. Then they have decreased physical activities to burn the calories that they usually take. And third one is the imbalance in hormones. The second point we usually see in most of the Indian women, where the physical activity is very, very less compared to Indian men. And particularly the housewives now, because of the advanced machinery that they are getting, they think that working in kitchen is like
switching on a power button and then sitting in front of TV serial. So it's not like that. Physical activity is seriously missing among Indian women. That's why we see a lot of obesity among them. And the second problem is, unfortunately, because of the adulterated food, we see a lot of hormonal imbalances also. This is what we have noticed in our patients. And these patients really need help in terms of like the kind of food they eat and in terms of like lifestyle modification rather than anything else. So these criteria have been already discussed, and coming to my main topic, different types of bariatric procedures that are available. So we have laparoscopic procedures and endoscopic procedures. I'm not going to discuss about open thing because open is abandoned now. It's absolutely not recommended by any guidelines across the globe. So laparoscopy, we have three different modalities where we have a restrictive procedure, then we have malabsorptive procedures, then we have a combination of restrictive and malabsorptive procedures. So purely restrictive procedures are laparoscopic gastric banding, then we have sleeve gastrectomy, which is a purely restrictive procedure. Then we have malabsorptive procedures, which are biliopancreatic diversion with a duodenal switch, or a jejunal ileal bypass, or a biliopancreatic diversion. And a combination of these two is what Dr. James has discussed, bypass and one anastomosis, mini gastric bypass. So endoscopy, we have different methods, like the balloons, the gastroplasty, and the liners. Liners are still experimental. Nothing has picked up in a commercial way. The commercial way, we have a lot of balloons, different types of balloons that are available, and then we have endoscopy sleeve gastroplasty, which Dr. Chandrasekhar has already spoken to you. So this slide shows differentiates between different types of procedures. The first one is the laparoscopic gastric band, which is a purely restrictive, and the second one is a sleeve gastrectomy, which is also again a restrictive method. Third and fourth are basically a combined procedures, and fifth one is a purely malabsorptive procedure, which is a BPD we call. The Roux-en-Y gastric bypass and mini gastric bypass, both are combined procedures where we have a restrictive component and we have a malabsorptive component. So I would like to show a small video animation. This is how we enter into the stomach with our laparoscopic ports. So we identify the stomach, then you have a duodenum, small intestine. So what we do in combination procedure, that is either Roux-en-Y or a mini gastric bypass, is we dissect the stomach into a small pouch, and we separate most of the body and the antrum of the stomach from the cardiac part or from the lesser curvature. So once it is divided, the small bowel which is there, depending upon the amount of BMI and the requirement of weight loss, we decide like what length of small bowel has to be bypassed. So in this picture, what they are showing is a Roux-en-Y gastric bypass, and the lower part of the ileum is again joined with the anastomotic part. So here you see the purple thing is the food that we eat, which is getting bypassed completely, and the gastric juices, which are shown in yellow color, gastric and biliary and pancreatic juices, they just get bypassed and they start mixing in the middle of the small bowel. So this causes some amount of malnutrition because most of the
B12 or D3, they get absorbed in the proximal intestines, and there are some deficiencies associated with all these malabsorptive procedures. So whereas coming to the sleeve gastrectomy, we just take the greater curvature of the stomach and make the stomach into a banana. So the natural digestive system, that is the physiology of the bowel, is maintained. The food digestion is maintained in a physiological way. So the amount of malnutrition associated with sleeve gastrectomy or a sleeve gastroplasty is minimum when compared to the malabsorptive procedures. So this is the consensus statement taken by multiple associations in USA in 2019, and they have come up with this article in 2020 in a journal for surgery for obesity and related diseases, wherein they have shown they have compared different kind of surgical procedures, and their recommendation is that sleeve gastrectomy should be the first one, considering the less amount of complications associated with that and the majority of the benefits that we see. If you take in terms of percentages, so sleeve gastrectomy patients, they usually have a weight loss around 25 to 30%, whereas the bypass procedures, they have around 30 to 35%. So if you look at it closely, there is 5 to 10% variation in the weight loss. So when you turn these percentages into kgs, they hardly have 10 kgs to 15 kgs difference. So considering the amount of complications or the malabsorptive disorders that they have and the advantages that they have, I think these 10 kgs and 15 kgs can be tried and lost with diet and exercises, which we have tried in our patients in Guntur, and I think we are partly successful in achieving that. So the current recommendation is a sleeve gastrectomy by that group. I'm not generalizing it, but the consensus, that is what they say. And second preferred one, or the thing that should be done, is one anastomosis mini gastric bypass, which is recommended when the sleeve gastrectomy fails for any other reason, or when the patient has regained weight and it has to be revised. So these patients should have a one anastomosis gastric bypass. So this is one of the patients that we did in 2019, just before COVID. So this guy is a 23-year-old guy and he doesn't have any comorbidities except for OSA. So because of his OSA, I have taken up this patient. We have done a sleeve gastroplasty, and he has lost around, from 137 to he became like 82 in last December. So that is 2021 December. Within a 1 year span, he has lost like so many kgs. So in terms of percentages, it is 92% of his excess body weight, which is quite significant. So 92% of excess body weight is a very good number, which we don't usually achieve with any standard thing, because in literature it says like 60 to 65% itself is a good number. This is achieved because of the constant motivation. Surgery is just a part of the weight loss journey, and if you want to get more results, you have to spend more time with the patient. If you are not ready to spend time with the patient, then there is no point promoting it. So I have a person-to-person, one-on-one discussion with the patients most of the times. This guy, because he is young and he's very energetic, he used to connect with me quite frequently, and every month he used to talk over and discuss his exercise schedule and his diet schedule. So we had a good discussion, and this is the result: 92% excess body weight loss. So this is where I'll end my talk. Thank you for giving me this opportunity. Thank you, Dr. Ravi and team AED.
Thank you so much, Dr. Adala, for giving us another vision. I'm happy and grateful to all of you, especially our eminent clinicians as well as surgeons, to attend the CME meet, that is Obesity Khalass. Thank you for sharing the vision with AED Hospital that is changing lives. And this day very soon will be one of that historical day when we have stepped on to another era where we all will look forward for a new beginning with a healthy life and healthy mind. Thank you so much, and thank you on behalf of Dr. Ravi K. Muppidi sir to host this event. Thank you very much, and have a great day. Time. The dinner is served. I would like all to please share your views and feedbacks and other suggestions while dining. Good night. We can conclude with the sharing the bouquets to the speakers. We will invite Dr. Ravi sir.